Now we're moving back to a presentation in the auditorium. Our next speaker is Dr. Ana Rueda-Benito. I'm very delighted to introduce Ana Rueda to our conference. She's the consultant microbiologist in Sligo University Hospital, and she really bridges that gap between research and clinical practice. And Ana has been central to how we've practiced, how we've responded to COVID, both in terms of infection control and diagnostics in the hospital. And this has meant that her practice, her knowledge and her research in this area has had to be, her practice and her knowledge anyway, has had to be absolutely A1. And I suspect time for research in that has probably been left to others, but actually learning from the research has been essential. And so we look forward to Ana coming to us and telling us about diagnostics and COVID. I hope you enjoy this as much as I will. Thank you. Yeah. And then you just have to press the button to
Well, hello. Thank you for the invitation to participate in this conference. It's an honor because I am more a clinician more than a scientist. So my view is very practical. First of all, I would like to talk about what is the... Sorry, how do you do it? Oh, here, thanks. I got it. So, I would like to let you know what I plan to talk about today. First of all, we need to meet the enemy. See, it's more or less the timeline of what we were facing just a couple of years ago. First of all, we needed to know what we were facing, and then we needed to know how to approach the diagnostic of this new virus that we were not familiar with. Well, in a way. So there were different ideas at that moment. It was the time was crazy. As you were saying before, the bombarding of information from everywhere. Everyone who had an idea just published it straight away. So it was very difficult to filter which information we wanted or we wanted to keep, and which information was not useful at that time. But in the end, as early as March 2020, we had a full sequence of the virus that we were facing. We knew that it would belong to the family Coronaviridae and the genus Beta coronavirus and subgenus Sarbecovirus. That is not really helpful unless you know something more about this family. So we were familiar with other coronaviruses in the past. 4 of them that we already knew are very low pathogenic to humans. But there are 3 more that are very highly pathogenic. And the difference is that these 4 have been with us for a long time. So humans have developed some kind of immunity for them. Whilst the others are pretty new, so we didn't have any immunity, especially with this SARS-CoV-2, which all of them have in common the fact that they are usually live in bats, and they use some intermediate host to jump the species and get it to humans. But the intermediate hosts seem to make some difference for their transmission and their immunity. So we have no immunity, no previous immunity against SARS-CoV-2, and that is why this is so pathogenic. So about this structure, it's a double-strain encapsulated virus, and that is important because that gives us some targets to try to address our diagnostic tools. The most important for us are the spike glycoprotein, the envelope protein, and the nucleocapsid protein. Those are important for both for genetic diagnostic and for serological diagnostic. And we also have this particular protein, which is a particular protein that is in the attached to the double-strand RNA, and it is, I want to say it right, it is it's a polymerase, sorry, it's a RNA-related polymerase that kind of corrects the mistakes in the replication of RNA. So that is important because that means that this virus is not so mutant as some other viruses, because it is able to correct its own mistakes. Basically, mutations are mistakes, and that works in our favor, believe it or not. So about the diagnostic approaches, of course, in the beginning of the pandemic, we had to identify the virus, start to know it. So the first approach was the viral culture. Viral culture. It's the best technique. It's the gold standard for knowing viruses, for assessing the viability of the virus. The problem is that, of course, it needs a level 3 biosafety lab, which, of course, in Sligo we don't have. And it's not for big numbers of samples because it's very manual and it has a lot of work behind. But it is good for research because it allows the calculation of the infection, the viral load, and the pathogenicity of the virus. This is more or less how a BSL-3 lab looks. It's a very complicated structure. For us, of course, in early 2020, it was not an option. So we just disregarded the whole idea. But just for the information, the viral culture looks more or less like that. Figure A is a normal cell culture, healthy. And on figure B, we see the cytopathic effect of the virus inoculated in this culture. About the antibody detection, we very early could see that from as soon as day -5, starting with the onset of symptoms, we could identify the virus in blood. So the virus was quickly replicating, and after a few days, after 8 to 10 days, the viral load was much lower, while the antibodies started to increase on day 2, 4, after the onset of symptoms. So that gives us a first idea that by the time we can detect antibodies, it is too late in a way for the patient, because we need to know that the problem that this patient has is COVID or not COVID. So going back to our structure, the antibodies, the antibody tests are addressed to detect antibodies against the spike glycoprotein and the nucleocapsid protein, basically. They were laughing at me yesterday at the lab because trying to explain a lateral flow assay in English, for me, it's a nightmare, but I will try, I'll do my best. So basically, it is a nitrocellulose membrane, which is impregnated with a conjugate of antibodies or antigen, could be, which are marked with either gold or latex, which are able to change color when they change their structure. So basically, in the sample pad, we put, it can be a drop of blood, a drop of plasma or serum, or even a drop of nasopharyngeal swab. And the sample here at this first step is kind of treated or separated. For example, if we put a drop of blood, the erythrocytes will be fixed at this place, and then the rest of the sample will flow through the pad to the next step. In the next step, the conjugation happens. So whatever is in our sample, either antigen or antibodies, depending on what we want to detect, will attach to these markers, as we said. And it goes through, and then the change of configuration makes that when they attach to the antibodies that are set in these bands, they change color. So basically, in the end of the flow, when the rest of the sample, the excess sample gets to the absorption pad, we can see the lines where the markers are present and they change their color. So if that makes any sense, we will see one band when we have only our control and we don't have any antibodies detected, and we have IgM where we have an IgM detected, or IgG, or both, which is the best case scenario, of course. This is more or less the same principle as for the automated ELISA assay. This is much better for big numbers of samples, of course. That is what we started doing at the lab early last year. And it's more or less the same, only we have the label conjugate has fluorescence, and it is read by a machine, not by human eye. If you had to trust my eyes, you would be in trouble. So what we saw is that the antibodies against proteins N and S could be detected after 1 week of infection. The problem is they have very low sensitivity in many cases in the first week. And say the highest sensitivity you can get is around 96% in the second week, although they have very good specificity. The problem is that the general recommendation is not to use any assay below 95, 96 sensitivity, because that is no help for big numbers of samples. We still don't know, the expert immunologist is talking after me, thank you for giving me a hand with this. We still don't know how long the antibodies stay active in blood. We know that we cannot detect them after some time, but we still don't know how long really we can expect them to disappear from blood. The neutralizing antibody is decreasing time, but the humoral response is still possible. And in some groups, we still don't know which is the response. As you can see, the problem with this is that sometimes you don't even know how are the levels, what is the relation in this case with IgG and IgM. Sometimes IgG appears before IgM, so, and the level of antibodies is still not clear. The other problem is that the assays are not standardized, because there are like hundreds of different assays in the market. They look for different targets, they use even different units, so there's no way, not yet, that we can put all those data together. So for us, it was not useful in Sligo lab, because we are a clinical lab. So we come to the king of the party, which is the nucleic acid amplification techniques, the PCR, our friend. So I would like to make a little story. The situation in our lab in March 2020 was critical, as usual. We were very short of space, and coronavirus hadn't even appeared. We were trying to find a way to expand the lab. We were short of staff. We were trying to fill in some scientist posts that have been empty for a number of months. We had no molecular diagnostic in-house. We had an instrument that had been purchased for enterics diagnostic, and it was in a corridor because we had no room to put it, because we didn't have a clean room facility. So we were sending, at the beginning, we were sending all samples to NVRL. These poor people in NVRL were overloaded, and we had a 4 to 5 days turnaround time, which is too long. So we decided to sacrifice some office space. Our senior scientists were good enough and resilient enough to sacrifice their own office to start our molecular lab. People were really good. The scientists were happy to take 12-hour shifts. We merged two teams, public health and microbiology, and even some people from serology were happy to work with micro, and we had to double the staff on call at nights. So in the end, we repurposed our new molecular instrument to perform SARS-CoV-2 instead of enterics. And so again, going back to our virus, PCR, what we do is a real-time PCR. And we detect, basically, with this instrument, detects the sequence for the protein S, protein N, and the oh, sorry, I always forget this. Well, the protein, the retro RNA polymerase, sorry. So this was the beginning of our lab, molecular lab. This is Helen, our scientist, getting ready to start. So we had our samples, we had our instruments, our friend Seegene, we had all our reagents, but at some point in time, very early, there was a lack in the market. There was a break in supplies for almost everything. We were struggling to get basically lysis buffer, which is kind of a magic potion to go to do your master mix, to do your PCR. So the lysis buffer just disappeared from the market. There was no way we could find them. So there was panic because we couldn't do anything. But thank God, the magic potion was not too far away. So our nice neighbors in IT decided to give us a hand and make some magic potion for us. So a big thank you for them, because they made some lysis buffer and also some universal transport media, because we were also short of swab kits. So yeah, that was really a big help at that moment. They kept us going. So thank you to Sligo IT for your help. So going back to our lab, you can do RT-PCR in two different ways. You can do it in one step or two steps. Basically, what you do when you do a one-step PCR is that you put everything in the same tube, and you do the reverse transcription and the amplification of the DNA in the same tube. But that that loses some sensitivity. So what we do is we do it in two steps. First we do our reverse transcription, and then we transfer everything. We add the DNA polymerase, and we transfer everything to our thermocycler to do the amplification. What is the difference between a normal, regular, traditional PCR and the real-time PCR? First of all, the traditional PCR is basically manual, because you have an endpoint PCR. You do a known number of cycles, and at the end, you take those samples and you run you put them in a nitrocellulose gel and you run an electrophoresis. And in the end, you have to use your own eyes again to read. You have a known number of copies. So you have to compare your sample to the known number of copies that you get. That is good for research. I remember myself, screwing a few of them when I was a trainee. Yeah. But the good thing is that we have an automated system, which is real-time PCR. In this, you have a thermocycler that reads the amplification continuously. So you are drawing this kind of graphs. So in any time during the amplification process, you can see what you have you can see the fluorescence, the amount of fluorescence that you get, so you can have an idea of the number of copies you are getting. So that is much easier because you don't have to trust the observer. You trust the machine and it is more accurate. So the steps of PCR, I'm not telling anything new. Basically, we have the RNA, we perform the reverse transcription, the DNA starts copying, and then we do the PCR which is the amplification of the DNA. So eventually you get a big number of copies of DNA, and you can measure your fluorescence with this graph. Along a number of cycles, you get more and more copies, and there comes a moment in time where the reaction becomes exponential. So you can easily measure the fluorescence. There is a threshold. Below this threshold, you cannot see any fluorescence. So you assume there is no template, there is no reaction. But above this threshold, you can read it, and you know how many copies, more or less, you have. So this is where the DNA amplification happens, and this is the kind of graphic we get. I will go back to this later, if you survive. So the PCR has the highest sensitivity available in the market right now. It's also very specific. Very specific. And another advantage is that we have some rapid tests available. We can get results in as quickly as 1 hour. And we can also have the opportunity of doing multiplex assays. That means that in the same sample at the same time, we can be testing COVID, flu, and RSV, basically, which is the most important things in this season especially. And we can know that they are positive, they can be positive from day 4 to 5 of contact. We don't have to wait until the patient has symptoms. So it's very good for us from the infection control point of view to control contacts and isolate contacts before they create more contacts. So it is very handy. There are other techniques, just ignore this. These are very fancy techniques. Some of them, the first one is isothermal. It was very used in the beginning, but now it is kind of less popular. And the other are very, very fancy. They seem to be the future, but they are not available yet for normal people like us. So, believe it or not, PCR is easy. It's not that complicated. The tricky thing is to interpret the results. I still have time. So, I will try to fly. So, basically, when you get your threshold here, as I said, let's look at the blue sample. It is a clear positive because the CT is the cycle threshold. It's the number of cycles where we start detecting the fluorescence. So if your sample goes quickly above the threshold of detection, you will have a very low CT value because the CT, the number of cycles is very early, is very low. If you have very low viral load to begin with, a very low number of copies, the amplification will be slower, so you won't get to the threshold until you make a big number of cycles. So the CT will be higher. And in the end, sometimes you don't even get any amplification, so that's a clear negative. That also helps us to decide if the patient is in the beginning or in the end of the infection. So that was tested by this lab. They are a lab specialized in coronaviruses in Berlin. They were the first ones to learn that when you have your coronavirus disease, after they ate, they couldn't recover viable viruses from the samples. So they decided that, of course, we know that the patient is not infectious after day 8 to 10. To be sure, we extended to day 14. Sometimes in immunocompromised patients, we know that they could be infectious after until day 21. And that is why, in some cases, we extend the isolation until day 21. And this is more or less the same story, but an English group. And they saw that after day 20, it was impossible to get a positive culture. And it was also in relation to the CT value. The higher the CT value, the less likely to get a positive culture. So, and that is the dream team. I am just ignore my figure in the center of the picture, but these people are the people who are doing the testing. Testing is not swabbing. Testing is this PCR, and these people are flying, and they have worked like lions. They are great. So, thank you. To them.
Thank you, Anna. That was really, really interesting, and I want to say thank you to your team. I think it's really interesting to see how the research affects the front line, but also how the resources we have are so important, and then to see how the team has adapted and just what generosity of time and effort people put into making this place as safe as possible. Also from a knowledge point of view, I'm sure if I'm not the only person that learnt an awful lot about the test there, so thank you very much. I'm glad to see, I was wanting to draw attention to the fact that online there is the option to ask questions over the Zoom, and we actually have a question online, which I might just ask you now. It says, what effect will this stress have on staff? Oh, sorry, I think that's actually from the previous session, so I don't have one online. Does anyone locally have a question? Oh, we have John again with a question. Thank you, John.
Thanks for a very interesting talk, and congratulations on getting the team up so quickly. Quality control, what do you use for internal, and is there any national overseas quality control, quality assurance program?
Yeah.
Can I just repeat that online for the ones who are listening in? It was about quality to control, and is there a national quality control standard?
Yeah, there is the INAP quality control. We have our quality program with them. But of course, the internal quality control of the tests are given by the manufacturer, and we perform it every day. So sometimes, yes, sometimes they fail, and we have to repeat the whole run, because if the quality control fails, you cannot accept any result.
We have another question from the audience. Teresa?
Yeah, thanks, Anna. Very interesting presentation, and you're always accessible to all of us, so thank you. I suppose what I was wondering, and it's something, because my department is involved with the staff testing, and I suppose there's just a bit of confusion from my point of view, is how soon or how after somebody has tested COVID positive, you know, we've often been said, well, there's no need to test them 3 months, or because it'll still show up positive. I'm just wondering, could you just explain that a little bit more? You know, how soon after they've tested positive do they remain negative, or do they not come back positive?
So the question, just for those online, the question is, how soon after you've had COVID do you then test negative for COVID? So that was the question. So could you?
It is very variable. It depends on the person. It is, as every infection, it's a relationship between the host and the pathogen. So some people become negative in 2 weeks, and some others are still positive with very high CT values. That means that the virus is not viable, but we are still detecting fragments of the RNA in the samples, but they can stay positive for months. That's why we don't recommend retesting them, because it could cause confusion. We know that once you've had COVID, at least in the next 3 months, you won't have it again. So that is why we don't retest people. Because if you retest it, then you have to go back and decide if that is a new infection, if that is an old infection, creates more confusion.
Thank you very much. Thank you very much, Anna. That was really, really interesting.